When reviewing a CMR scan, it's important to systematically go through cardiovascular structures within the context of the overall anatomy imaged. Pilots, taken across multiple planes, cover a wide anatomical area. I find it helpful to use reporting templates. A standard template would include comment on the ventricles, atria, valves, great vessels, and pericardium. Different sequences are used for myocardial tissue characterization depending on the clinical question posed and underlying pathology noted. Prior to contrast administration, T2 weighted short tau inversion recovery images, T2 STIRs, may be acquired. Gadolinium contrast is often administered. Perfusion CMR may be required in selected cases. Start scan evaluation by looking through all your multiplanar anatomical datasets. This is, for me, the optimal time to discover any extracardiac pathology. If you do see anything, note it down straight away into your reporting template. Next, I use the follow the blood flow style of reviewing to narrow in on the cardiovascular system. So, starting from the inferior vena cava and following blood flow in and out of the heart until you arrive back into the abdomen at the abdominal aorta. Along the way, you will reach some preliminary findings. These can usually be crystallized by detailed review of specific imaging planes using the spectrum of different sequences used during the study. Again, fill sections in as you go along into the standard reporting template. Conclusions should be succinct and listed in descending order of clinical importance. A final unifying summary sentence may be required if you end up with a list longer than 5 or 6 at this stage. Referrers read this crucial conclusion section, not necessarily the entire structured report. Regarding the ventricles, you might comment on volumes and ejection fraction, regional wall motion, and wall thickness and mass. Use appropriate reference ranges for your data. Regarding valves, information from echocardiography is wonderful to have to hand at this stage. Evaluate valvular structure and function. Accurate volumetric data will provide useful information for your assessment. The great vessels will require a brief or more detailed comment depending on the absence or presence of pathology respectively. Are they of normal caliber? If dilatation is present, what is the anatomical description of this abnormality and what are the functional consequences? As we saw earlier on, there is a long list of Class 1 indications for CMR in acquired diseases of the vasculature. T2 weighted STIR images are ideally evaluated side by side with images acquired post-gadolinium contrast. High signal intensity on STIR sequences indicates a high water content that suggests active inflammation and/or edema. In current routine clinical practice, perfusion CMR analysis primarily requires qualitative assessment regarding perfusion abnormalities. Fully automated quantitative techniques are becoming increasingly available. Contrast enhancement after gadolinium administration is a crucial aspect of clinical CMR. Early imaging can detect microvascular obstruction. This phenomenon can also be detected during a rest perfusion study and at LGE imaging. At this early stage post-contrast, higher signal intensity may be noted in areas of myocardial hyperemia, such as occurs in myocardial edema. Low signal intensity during early gadolinium enhancement within the left ventricular blood pool is suggestive of thrombus. Late gadolinium enhancement is one of the most fundamental techniques in CMR and will be covered in detail later on in the course. To conclude this talk, develop your own routine for looking through all the images available and communicating your findings in a clear manner.
Case 7 is a 33-year-old gentleman with an underlying diagnosis of PDA, aortic coarctation, and VSD. In 1985, aged 3 days old, he underwent a subclavian flap repair of the coarctation, PDA ligation, and PA banding. The following year, he underwent VSD closure with reconstruction of the PA. In 2001, stenting of residual coarctation was performed. CMR has been requested as part of his routine follow-up care. In the bottom left here is shown the details of the sequence, and also on this panel. And I'm going to now take you through the images acquired. You will now have available to you the quantitative and qualitative findings from case 7. In terms of the learning point, just a few things to say about aortic coarctation. Congenital abnormalities of the aorta, pulmonary arteries and coronary arteries may occur in isolation or in association with other congenital lesions. The ability to assess these structures by echocardiography becomes progressively more difficult as patients become larger, and CMR is an important non-invasive alternative. Coarctation of the aorta refers to a narrowing of the aortic lumen. Most are juxtaductal, occurring opposite the entry point of the ductus arteriosus. The preductal form is located proximal to the ductus arteriosus and often associated with other major cardiac anomalies. The postductal form is located distal to the ductus arteriosus. Aortic coarctation is associated with cardiac defects such as bicuspid aortic valve, VSD, and mitral valve defects. Non-cardiac associations include intracranial berry aneurysms. Quite a few collaterals are seen on this image. Percentage of collateral blood flow can be calculated using CMR. Measurements of flow are taken just distal to the coarctation site and in the descending thoracic aorta at the level of the diaphragm. Normally, flow at the distal aortic arch is slightly higher than that within the descending thoracic aorta. With significant coarctation, this pattern becomes reversed and increased flow is now quantified at the diaphragmatic level due to collaterals. CMR is used for assessment before and after intervention. It can delineate anatomy and provide information on severity through quantification of peak velocity at the obstruction site. Blood flow across the stenosis is recognised with cines, and these are then used to position the planes required for velocity mapping CMR. Flow velocity mapping techniques across the coarctation measure blood flow velocity and a pressure gradient then estimated using the modified Bernoulli formula. Flow velocities may normalise in significant coarctation with extensive collateralization. Case 8 is a 19-year-old gentleman with Marfan syndrome, and this is his follow-up CMR study. In the bottom left-hand corner and down this panel are details of the sequence, and I'm going to take you through the images. You will now have available to you the quantitative and qualitative findings for case 8. In terms of reporting on the aorta, including a table comparing up-to-date aortic measurements and previously available data is extremely helpful in your report. Measurements can include those taken at the aortic annulus, sinuses of Valsalva, sinotubular junction, ascending aorta at the level of the RPA, upper ascending aorta, mid-aortic arch, and descending aorta, both at PA and diaphragmatic levels.